Hello there, I'm Miranda Gretton, and this is Take a Moment with NCHC, the show where we talk to you and your colleagues about experiences that affect you. Listen on your drive between patients or in your downtime, whenever you get the chance to take a moment.
In this episode, I talked to Joanne Green, Senior Coordinator for the Out of Hours team, about how they triage and the difference the Ageing Well programme has brought to the emergency response teams.
Hello, my name's Jo Green. I'm a Senior Coordinator for the Out of Hours team, which is based centrally in Norwich, which outreaches to North PCN, to South PCN, and to obviously Central Norwich. We have teams in the West as well. We have one team of a nurse and a driver in the West, and we also have a team in the East. And since Ageing Well, we've amalgamated with all of these teams, and we have a central coordination with a triage team from Norwich, which is where I sit most nights.
I've heard Ageing Well, the term, alongside another term, urgent community response. Are they one and the same? Could you tell us a bit more about it?
Well, Ageing Well was obviously part of the long-term plan, and one of the things was to try and keep people out of hospital. Within our area, we have a very large ageing population, and therefore, as you grow older, there's more needs and there's more things that can go wrong. And I think Ageing Well has incorporated the ability to prioritise and support these people to stay at home. It enables us to work much more effectively using technology, maintain patient flow through the system. The emergency response is 24 hours a day, 7 days a week, and the out of hours team is only just one part of that.
We hear the description of Ageing Well and urgent community response, and it makes sense kind of on paper. To put it really simply, this program has meant that we can prioritize something, really urgent by triaging and working to particular time windows. That helps that patient to stay at home and stops them from going into hospital. That's the bottom line, isn't it?
Absolutely. And that happens on a nightly basis, that we're reducing the hospital admissions. Other services like the ambulance service are under so much pressure at the moment, they can't possibly always get there that quickly, as quickly as we'd like them or the patient would like us to. So it's really ramped up for us that we need to do absolutely our best to try and keep people well and out of hospital.
With triage, you would have prioritised the call pre-Ageing Well. So what's the difference? What does Ageing Well mean to the prioritisation that you didn't already have?
No one was counting, whereas now there's that expectation that you're going to meet it. How they would do it before Ageing Well was they would be in their cars visiting and triaging, which is really difficult. So this has been profound difference to have a triager and a person actually coordinating, looking at the logistics around who can do what and where is the best place. The Ageing Well process, what we have to do is then incorporate that into the process and what we were doing so that we could respond to that 2-hour window and to successfully triage appropriately and keep patients safe when we put them under the umbrella of the 4-hour or 24-hour window. And so there's a triage team that comes in at 5:30, and they're starting that process so that we make sure that by 6 o'clock, when our nurses come in, that they're ready to go and they've got visits to be seen straight away. It's a very efficient service in the fact that it makes sure it's got all its proper equipment in place, it's got bladder scanners charged, we've got observation kits, all the equipment we could possibly need overnight for any eventuality is checked and dated and is there, and that's really good. So the processes that we have in place to make sure that we can be efficient are there as much as possible, and we've got the triage process had to be altered slightly so that we could fit that into the Ageing Well programme. So we actually looked at mapping the process out. So we would incorporate times on ledgers and order of priority on ledgers so that the nurses very quickly knew who needed to be seen quickest and first. They knew when the times were breaching and how they would prioritise themselves. And armed with as much information as possible from that triage encounter, we need to be more effective with our time and how we get to patients, which is really important. So we have WebFleet, which is a satellite navigation system, which will make sure that we've actually pinpointed to the door of that patient. We also know by looking very easily where our nurses are, and we will try to utilise them very logistically, because in that way we respond quicker. So it's not about how many patients that nurse sees, it's about where they are and how quickly they can get there. Obviously, there's times where you have to pull somebody else in to support them, but if we can keep all of the areas across Norfolk, Suffolk and Waveney covered, then we've got a much more effective service.
You're right. And I think that word process, it just quite a lot of the time when you're dealing with people and high emotion in the middle of the night, sometimes process is not what you want to be talking about. You know, the way a clinician's mind works is I need to get out and deliver that care. Come hell or high water, whether it's at my own risk or not, I'm going to get out there and deliver that. So someone has to be there providing those processes to keep everybody safe, not just the patients, but the staff as well. When you've only got 2 hours, every step of the process counts.
As being efficient, you know, making sure that those cars are booked out to the drivers and the nurses, the boxes are ready to go and they can get out the door. I mean, I want everyone out the door at 10 past. As soon as they start work in the car, off they go.
So pre-aging well, it could have been that, you know, the call was being triaged, then they would have packed their bag and put the things in the car. And whereas now you've incorporated that as part of the process to meet that criteria.
Yeah, and I think also, you know, having the process in place to make sure that everything's ready to go through that the night before, looking at what tomorrow brings with the staffing, with everything is vital, you know, and to make sure that we've the best technology that is going to enable that. So it works sometimes and not always with Webfleet, pinpointing people to the right address. But what I'm selling now to everyone is, if you go through that finite process of getting people every time to that front door, we're just saving time.
But it all adds up, doesn't it? It's, you know, it might seem like a small thing to get someone to the front door without having to drive around the area for 10 minutes, but that's 10 minutes in a
Yeah.
2-hour window. Every second of that 2 hours counts.
Yeah, it really does.
It sounds like a fantastic service. I mean, I can imagine it's what patients want, to be at home, to stay out of hospital. Why is the Aging Well programme particularly important, not just for patients, but also carers, and particularly in Norfolk and Waveney?
For carers, especially at night, it's a really worrying time. And if someone's really ill, now that could be within our out of hours service, our majority of referrals are around catheter care and around end of life. Maybe you could be a carer that's there 24 hours a day. You could be a carer there that has limited knowledge. You could be a carer that is not paid, but a relative, and they are in a position where they're having to input into that patient's care, into their loved one's care, and that makes a huge difference as well. The fact that it's a loved one, you know, that it's a really frightening experience if someone's in pain through the night. That just exacerbates. And I think, you know, to respond quickly, what you can do is you can then reduce some of their anxiety and some of their concerns and worry. You know, being that clinician that can offer advice and onward referral as required overnight is really important. And I think within the out of hours team, we've really grasped that need to be integrated so that we're referring that knowledge onto GPs, onto the day service, so that they can have an understanding of what's happening at night. And, you know, carers need that support, and they need to be listened to, and they need to be referred on to other services that may take up some of the stress throughout the day. And we've got all of that knowledge base, and we've got the ability to refer very quickly.
I think if it's a family member, I mean, I wonder whether that can cloud your judgment a little bit, especially in the middle of the night. And you think you know what to do as their carer, but then something goes slightly wrong. So to have that reassurance that somebody who does know what to do is coming, it's that reassurance, isn't it?
Definitely. And I think even through triage, this can be done so well. You're doing your telephone triage and you're risk assessing what the problem is. You're seeing how we can help. You're seeing what needs to happen and what the risk is if we don't visit. So that's constantly on your mind. And if it's something that can be resolved over the telephone, that's great. But you still need to let them know that you're there. So it's really important. And I listen to all of my colleagues on the telephone giving that reassurance and saying, look, we're here all night and we'll be by the phone, and if you need us, we're here. And I think that's a huge part of it. What we tend to do as well is we'll hold these patients on our caseload overnight. They are our responsibility. We'll hold them and we'll call them back if we need to, and we'll keep giving that reassurance until they're able to rest or go to sleep. you just don't know what's coming in at night. It's all age groups, it's all problems, it's really empowering to be able to respond quickly, and when they need it, it's a really good feeling to know that you've got someone through the night.
So what kind of patients do you typically see then in out of hours?
We're seeing more end of life as they're discharged from the acute unit more quickly, because obviously there's that need and demand on the beds, and also it's patient choice, which is really important. And most people, let's face it, want to die at home, don't they? So often it's very late in the afternoon that they come out, and then that's when we're going out to see them, relying on that good communication around when is good to use end of life drugs with them before they come out, and making sure they've got all their equipment in place, which usually 9 times out of 10 happens from the acute unit. That is in place beautifully. We're going in a lot to give assessment of pain relief, nausea, vomiting, agitation. More people are deciding with the respect form that they don't want to go into hospital anymore, that they'd rather stay at home and be treated in a palliative way at home. And we're seeing more of that come in. Also, block catheters is another one constantly. The long-term plan is the fact that we need to get much better with our technology, and Aging Well has enhanced that with, extra funding for bladder scanners. It's really increasing and reducing that risk of hospital admission, because we're really on the ball. Having more staff to be able to be very effective in our decision making on whether or not we visit a patient, in what order and what priority according to need, and Aging Well with the extra funding has done that, which is incredible.
That sounds amazing. I mean, that's the dream, isn't it, for a triage team to be able to triage, know the priorities and to prioritize effectively. But if you're a patient, surely every issue you're having is an emergency to you. So when that call comes in and they're saying this is, life and death, how can you prioritize those calls?
Well, it's very simple, because as you're going through the triage process, you just never know what's coming in. So there's always someone being bounced back, maybe, so that you can get to that visit quicker. That's very difficult conversations. You have to be really skillful in how you actually talk to that person. So, throughout the triage process, what I will say to that person is, I will be honest about the time frame that I will be allocating that visit, and I will give them a rationale for it. I will also say to them, we're going to put this as a priority visit, so it's going to be within 2 hours. Invariably, we get there a lot quicker, but it's giving them a realistic idea of what the time frame is going to be, because I think, to be realistic and honest, they can take that very well, and they understand what other commitments there may be. So if somebody tells me they're not in pain and their catheter's blocked, I will be saying to them, okay, so I'm going to pop that under a 4-hour window, but we will probably see you before then, but we're prioritising those in pain at the moment. If anything changes, call me back. And that's, I think it's that dialogue you use of reassuring them that we are coming to them, and we will get there as soon as we can.
It's all you can do, isn't it? Be realistic and transparent so that they know what's going on, and constant communication. I'm interested to know though, how is it going? Are you hitting those targets? Because 2 hours doesn't sound like very long.
No, we are hitting the targets really well. I think sometimes we do have problems if the day service have had problems with their reaching their 2-hour targets, and that is categorically a priority of ours to actually meet those as soon as they come on. So there will be some breaches initially, because they would have breached sometimes, or near to breaching, when they reach us at 5:30. But in saying that, they then become top priority, and that's the beauty of Aging Well and knowing the length of time, the breach, and what should be seen first. Usually, we're meeting all our targets within our out of hours service timeframe, which is really good. There are problems in the morning, and which I know that the trust are working really hard to resolve, and we've put in place some changes to be able to make this better. It's that handover period in the morning when the two teams, one finishes at 8 and one starts at 8, and there's sometimes a problem with the overlap. So we're trialling in Central, where we actually just, those patients that may have we've not been able to see in the last hour are put straight onto a ledger so that they can be picked up and visited straight away.
You mentioned Webfleet, and I mean, obviously we live in Norfolk. I mean, it's vast, Norfolk and Waveney, this vast area with all these dark back roads that people have to travel down and not very much phone signal. And we know the challenges that Norfolk presents. I mean, you've got web fleet, as you said, which sounds great, but what other particular challenges do you face in order to try and hit those targets?
It can be roadworks. I mean, they're terrible at the moment. There's roadworks absolutely everywhere. Getting back in touch with the patient can sometimes be difficult. So in triage, even before you've got on the road, sometimes when you're trying to call them back about their referral, they don't answer the telephone. And sometimes they can't hear you on the telephone, which is really difficult. So there's some of the issues that slow it down. Weather is a big one. You don't want to push staff too quickly. You don't want to make them drive too fast. You don't want to put them under too much pressure. So I think it's, if you're going to breach because it's not safe, that's a shame, but that will happen in the climate. But no, mostly with Webfleet, we get there, we get straight to the door, but it's sometimes how people answer or whether you can get in, which is sometimes a problem. But we're all geared up with our torches, and the drivers support us really well. And we're actually trying to change that slightly in the fact that we'd like to have a more sort of nurse driver with skills around being an HCA, which would be really fantastic, because you can see how the future could possibly move forward, if we could respond to people who had fallen. But yes, we're hitting most of our 2 hours, unless it's a very extreme day where there's been problems and lots handed over. And then it's just reprioritising yet again.
Absolutely. And a lot of that will be out of your control, like you said, with various different factors. So it's not always that, you haven't been able to get out for obvious reasons. I think it's a real spotlight on the triage teams, whether they're day or night triage teams. It's obviously you have to be ridiculously skilled to be able to assess somebody's need as it comes through, when, as we said, it will be an emergency to that person because it's the most important thing that's happening to them right in that moment. So for the triage person to be able to say, let's talk it through, let's be very open and honest and see what's really going on, and then let's assess that priority and prioritize it correctly. That's a huge set of skills that is actually beyond clinical, so to have all those skills and to be able to do that so effectively and still meet those timeframes, I think is absolutely amazing.
Yeah, it's a real skill. I really do think there's, as you say, there's so many skills around that. It's that ability to be able to really listen to people over the phone, really listening to what they're saying, and you can get a level of understanding of where they are, not only that whoever they're ringing about, but themselves, and what they need emotionally, or not just physically from us. You hear some really distressing calls. You're really pushed to your limits sometimes. I mean, I'd been on the 8 o'clock shift. I was coordinating from 5:30 in the morning, so I was taking over triage at that point, and that gets really difficult at that point, because you obviously have less resource at that point. East Coast, who we cover, which is Great Yarmouth and Lowestoft up to Southwold, they finish at 7 a.m. And so if you get a call in at 6:30, sometimes they can't get there. And we had the most distressing call at 6:30, which was someone who was dying and then had a massive hematemesis. So they had a massive bleed. And this was new. This was not expected. And there was an 86-year-old man on his own at home. And I could hear him. I could hear him on the phone. So he was on a mobile to the ambulance, and he was on the landline to me. And he couldn't answer the questions. He was so absolutely beside himself with worry and anxiety and grief and all sorts of things. And all I could do was I got as much information once he was talking to the ambulance service and holding the phone to me, to be able to think, well, if the ambulance can't get there, I'm going to get the nurse who starts at 7 o'clock to go straight there. And so that was, a task through to a telephone call to make sure that every avenue was covered, to get someone to go out there, because it was either going to be support for him. Well, it was definitely going to be support for him. It was either going to be a stat dose for that lady or a verification, one or the other. And it was just getting somebody there. And I know that patient was visited soon after 7 o'clock. So, it does get really tricky, and it is sometimes very difficult, but it's those key communication skills over the telephone which are really vital, and that understanding of what is needed and just chucking everything at it sometimes.
And the teamwork as well. I mean, to come out of something like that, you can't just put the phone down and pick up the call to the next person. You're going to have to speak to your colleagues. You're going to have to find it within yourself to get back up and do the job again. And that must
Yeah.
mentally take its toll on everybody.
Yeah. And, sometimes in the middle of the night, people are just even more vulnerable, aren't they? Or in the early hours, they probably haven't had any sleep sometimes, some people who are ringing earlier. But it's just that kindness, compassion and empathy and effectiveness and all of those things that are in our trust vision, which I believe, we all believe in, which is to keep people in their own homes as much as they can. I mean, an admission to the acute unit just absolutely is not great for someone who's aging. It just isn't.
Especially as we're still feeling the effects of a pandemic. The last thing we want to do is be posting people back into hospital.
Definitely. Aging well, is about prioritisation. It's about ensuring as clinicians that we can understand the situation that individual patients are in and utilising that fast response and to, think out of the box when it comes to how you process things within your service and how you communicate effectively and how can you always improve upon it, because getting to people quicker means that they do stay well and they do stay out of hospital.
Thank you for listening to Take a Moment with NCHC. If you've enjoyed this podcast, please visit the podcast intranet page to leave a comment and for details of our other episodes. You can also follow NCHC on all social media channels.